That's the reason why we have to have these conversations. It's
Yeah.
because without actually educating people about what options are available to them, they're going to just say, doctor says this, yes, I'll do it.
Right. It's lovely to chat to you.
Thanks for the invite, Carmen.
Lovely to connect with you again after so many years.
Yes.
Why don't you go ahead and introduce yourself and let us know who you are, where you're from, and what it is that you do.
Yeah, so my name's Dale Creamer. I'm an interventional radiologist, and I did my undergrad at UKZN. That's where I know Carmen from. And I then went to Cape Town and studied radiology at the University of Stellenbosch. And after that, I went to Canada to train in interventional radiology. So
how long were you in Canada for?
just a year.
Okay, nice.
Just a year. So,
Yeah,
but quite an intense year.
I'm sure.
And we were trained by some of the world's best interventional radiologists. So it was quite a high pressure environment.
Yeah,
But I think we learned quite a lot. Yeah.
I'm sure you did. So, learned abroad, brought back your expertise for us to take advantage of, I suppose, in the country. But what is it really? I mean, okay, so let's maybe take a few steps back.
All right, cool.
Why I'm interested in what you do.
Okay.
I get tons of women on my social media, in my inbox, in my email, wherever they can contact me, asking for help with period problems.
Right.
And one of my biggest issues is that, unfortunately, as doctors, one of the things that we prescribe for patients with period problems is the birth control pill. Next to the birth control pill, we have surgical procedures. And while not all gynecological conditions are warrant surgery, a lot of them don't warrant the pill either. That's my big bugbear, right?
Yeah.
But I suppose when it comes to options, one of the things that I find is that there are other options available to patients. They just don't know about them.
Yeah.
And one of the things that we started chatting about is fibroids.
Yeah.
And I, to be honest, didn't realize that there were so many other options when it comes to, or at least that there were other options when it comes to managing fibroids. So a lot of the patients who contact me will have heavy bleeding, difficulty getting pregnant, a pelvic pain, fullness in the pelvis, and they've been told that they have fibroids. And then they ask me, what can I do to shrink my fibroids? And oftentimes they've been told the only way to fix it is with surgery.
Yeah.
So maybe you can share a little bit about what you do and some of the alternative thoughts or approaches when it comes to managing fibroids.
Yeah, so it's quite interesting because some recent publications say that in sub-Saharan Africa, 60 to 70% of all Black African women will get fibroids in their lifetime.
Yeah.
So it's extremely common.
Right.
And as you say, the presenting features are heavy bleeding, you'll have pressure, you might have urinary incontinence, you might feel a fullness in your abdomen. And the current management is either hysterectomy, is when they remove the uterus completely,
Right.
and myomectomy, where they actually go and remove these fibroids like tennis balls
Right.
out of the uterus. Yeah, so it's quite, I mean, you can imagine it's quite an invasive. Once you have a surgery like that, you're going to have post-operative pain. You might end up, complications. Either working inside the abdomen or opening the abdomen. It's going to have. There's always these known things that can happen with surgery. And from our side, interventional radiology, in a very basic way to describe it, is like, if you think about how we look at pictures so if we look at a CT scan, if we look at an ultrasound, MRI, etc., there we use the same imaging modalities that we use to diagnose patients. We use them to actually treat disease as well. So it gives you if you imagine, when you look at a CT scan, you're kind of looking through the body, or if you're looking at an X-ray, you're looking through the body. And we use those imaging modalities to look through the body and use small catheters and wires and some contrast dye, which you can see inside the blood vessels. And we use that to navigate our way to the blood vessels that supply the fibroids. We actually access a small blood vessel in your wrist, which is called the radial artery. And And believe it or not, that's it. You don't even have to take your clothes off. So
you're saying, wait, let's just rewind. It's a bit of a mental image that we have to have here.
Yeah.
You're saying that you're able to operate
yes,
on women
yes,
in their pelvis,
in their pelvis, yes,
through their wrist.
through their wrist.
Wow, we've
Yeah.
come a long way.
From my training in Canada, it's like everybody knows about this procedure, and I think one of the reasons why we wanted to go and train in Canada and to bring back the skill to South Africa is there's a lot of potential in patients understanding that there are options in the minimally invasive way or context where you can. I can work through your wrist. I just did a patient now where we went through the wrist, and then after we are finished, we put a little band-aid to hold and compress so that it clots off, and she's up and about. She's got a little bit of constipation. We sorted that out, but the constipation usually happens because we give her some pain medication as well.
Right.
But the most important thing with this procedure is to manage the pain. So what happens in the procedure is that when we use these catheters to get down into the uterine arteries, we inject this dye to make sure that firstly you have to exactly know anatomy, you have to study it really hard to get there, but you have to understand the anatomy of the pelvis and what supplies the fibroids. And we park these little catheters in these blood vessels and inject very small particles. And if you imagine what these particles do is that they go to the fibroid itself, and then they block the blood supply to the fibroid.
So essentially you're starving the fibroid.
Yeah, and then the fibroid doesn't like that. The fibroid likes blood.
Right.
So the minute
It's a vampire.
Yeah. So the minute we inject these particles in, the fibroid starts getting angry, and then it's not really happy, but it starts eventually dying off, and then it shrinks and goes away.
Wow.
Yeah. So there's only an initial, I would even say 12 to 24 hours, which we have to be quite careful with pain management. So that's why we have very, very well researched and documented pain protocols. So we know what medication to give patients before the procedure, in the procedure, and after the procedure to manage their pain. And then once we've gone past that 12 to 24 hour window, it just gets less and less over about 2 weeks. In fact, after the procedure, most people who do kind of desk work or sort of low, you're not really super active, you can almost go back to work in a couple of days.
Wow.
Whereas if you do a hysterectomy or myomectomy, you're pretty much out for 2 or 3 weeks.
Sure.
And you might
easily.
still have pain, you might have sepsis. There's a lot of complications that can occur.
Okay.
But with this procedure, you can have it, and then you can literally get back to life pretty soon.
You mentioned pain,
Yeah.
and it seems to be, while perhaps, I suppose everyone's pain threshold is different.
Yeah.
Most people may have a bit of pain, but nothing compared to major pelvic
No, you can't compare them.
Right.
Yeah.
Any other side effects that people may be, or can expect rather, with the procedure?
Apart from pain, no.
Yeah.
Yeah, because it's so minimally invasive, the risk of sepsis is extremely low. When I say it's minuscule, we're just working through a small little hole.
Right.
So every procedure has risks, but when comparatively, if you look at anything else that's on offer, there's nothing that can match it.
Wow. How many fibroids can you do? Is there like a limit?
No.
Wow.
So just the more fibroids there are, the more hungry they are, the more particles we have to use.
And are these particles toxic?
No. So these particles are all medical grade and tested and
Right.
used all over the world. This procedure is well documented. It's got more than 30 years of research behind it. And these particles have been created and designed to perform the function that they need to perform, and with very, with ease, with ease for me.
Any reason why? Of course, I'm sure. It sounds like you enjoy your job.
I do.
And
I
I'm
do.
sure you have many very satisfied patients.
Yes.
Because to me, it sounds like, just from what I know about gynecology and just some of the people that have contacted me with being stuck, almost feeling like they needed to earn their surgery, but they were also afraid of getting surgery because of some of the complications that may come with it. I'm just curious. I mean, I know that we tend to be a little bit behind the curve in South Africa.
Yeah.
But if you're saying that, this fibroid embolization has been researched for over 30 years, I'm wondering why we don't have more access to this procedure in South Africa.
I think this is the reason why these sorts of conversations are so important. Our colleagues in gynecology and obstetrics and gynecology may not particularly fancy it because it's taking away work from them, maybe.
Okay,
possible. I mean, essentially, this is now removing the need for surgery.
Right, major surgery.
Which
probably costs a lot of money to do.
And although I have to admit, some of our, some of the colleagues that refer to me pick the patients well that they think would maximally benefit from this procedure. But there's also some that are very old school and think that their way is the best way, and these interventional radiologists must stay in their lane. South Africans, I'd say our doctors in South Africa, it was quite an experience for me to go and see how first world medicine works. And how open-minded people are. And I mean, the interesting part is that patients and patient-driven solutions is what is happening in developed healthcare systems, where patients are actually like, I know my body, I know my problems, I want to find out what's actually happening and what's available to me, so that I don't just say, you tell me this, I'll say yes.
Yes.
So they actually make the decision which is informed. So that's why it's great to have these kinds of conversations.
I'm so glad you brought that up, because one of the things that I always tell people is you need to take agency for your health.
Yeah.
You have to stand up for yourself. You have to ask more questions. You have to do your research. And obviously that's not to say that you're going to become Dr. Google and know more than your doctor. That's obviously never going to happen. But I do think it goes both ways.
Yeah.
The patient needs to be educated and be able to have a voice, but also doctors need to also be a little bit more open-minded. And you mentioned in the first world countries that is the tendency, that people don't feel threatened by their patients asking questions or like wanting to know all their options. I do feel like in our country, the culture is for doctors to feel like, I'm the doctor, you are the patient, and I know everything and you know nothing. But I do think it's changing.
Yes.
And I think that with access to information, access to AI even, it's amazing what's happening in the AI space, where patients can now get educated literally like that, with all the world's information at their fingertips. So yes, I do think that it is important for people to feel and know that there may be other options. Don't be afraid of having that open conversation with your doctor. And if you've tried and you met with a brick wall, get a second opinion. And do your research. You've got a website, right?
Yes.
So patients perhaps who want to learn more about the procedure that you're describing, and others, because you do lots of other things, not just fibroid embolization, we'll share your contact details and how people can kind of get hold of you. Is there anybody who has fibroids who fibroid embolization is not an option?
Sure, that's a tricky question. So I think that sometimes there's been a lot of controversy, especially amongst the gynaes, who believe that when the blood supply, the ovarian arteries and the uterine arteries can sometimes communicate.
Okay.
Right? And that's called a uterine ovarian anastomosis.
Right.
And the issue that the gynaes keep on bringing up when they try to talk badly about this procedure is a very rare variant. Firstly, it's quite uncommon to have that anastomosis. But they talk about when you do the embolization, that sometimes you can have something called non-target embolization, meaning that those particles, instead of only going to the fibroids, they also go to the ovaries and can cause premature menopause. So this is the reason why it's very important for our patients to understand that an interventional radiologist is a super specialist, right? There are many radiologists in South Africa that have caught wind of this procedure and have now decided that they are interventional radiologists with no training.
Oh, wow.
and they
That's
are,
scary.
and that's so. The problem is that our patients don't know. Firstly, you must explain what interventional radiology
ask your doctor to show you the qualifications.
and then on top of that, then they hear this guy is he calls himself or she calls herself an interventional radiologist with no formal training,
Right.
no qualification. So just to be clear, I'm fellowship trained in Canada and I have a European qualification in interventional radiology. So in South Africa, that is as high as it gets. Right. So I think the thing is that patients who are really, really wanting the best outcomes, they have to go to trained interventional radiologists, where even if there is a uterine ovarian anastomosis that we spoke about, we are able to actually prevent and block and redirect flow because we have the training to do so. Right. So anyone who's a radiologist and goes and fiddles around when they're when they're training as a resident or registrar, they'll say they know something. But you only are really an interventional radiologist when you know how to manage complications and prevent complications. Right. Because then you've actually really studied and understand everything about the procedure instead of just doing it because you can. And it's our health at the end of the day, right? So again, it comes back to having agency over your health and well-being. So again, do your research, make sure the person that you're going to is qualified to do the procedure that they claim that they're able to do, right? A bit of a difficult conversation to have with the doctor, I guess. Like, show me your qualifications. No, but I think isn't that the patient's right? Because at the end of the day, it's your, for me, if I'm going to go and see a doctor for whatever healthcare problem, I'm going to do my research about that doctor. I want to know exactly where you trained, how you trained. I want to find out what people have said about you. I want to know everything. Because at the end of the day, with us as doctors, we have a very small community. News travels fast. It does. So you need to be able as patients to tap in and find out what's going on about before, and find out about your doctors and make sure that you're picking the right doctors. Sure, I 100% agree. So you mentioned one of the complications that may potentially happen is if you were to get this procedure done and blood flow to your ovaries were to be affected. Now that is kind of a red flag for me because one of the things or one of the reasons why women often seek assistance for fibroids is because of fertility issues. Yes. And if you were to be operated on or have this embolization procedure done and blood flow to your ovaries were to be impacted somehow, obviously that would have implications for your fertility. So it comes back to really understanding the person who is performing the procedure and making sure that you perhaps even have that discussion perhaps beforehand to make sure that you are safeguarding yourself. So fertility issues shouldn't be a risk provided that the person who is performing the procedure is qualified to do so. Have I got that right? So at the end of the day, right? So firstly, those shunts or the blood supply, the sharing blood supply between the uterine arteries and the ovarian arteries is a rare variant, right? Yeah. That's firstly. Secondly, is that when you are trained, just because you're having the procedure doesn't mean I'm going to embolize. Right. If I am not happy to embolize, I will not embolize. I will not put the patient at risk. Okay. Yeah. So I think that needs to be clear. Right. If I go and I find that there's something that I can't manage, I would rather stop this procedure and refer it to my surgical colleagues to remove the fibroids. Right. Because surgery is still an option. So I suppose when we're thinking about like the stepwise approach to managing fibroids, embolization is basically non-invasive, or less invasive. We'll say really, really minimally invasive, right? Okay, and then essentially there would be perhaps a group of patients who would unfortunately not qualify for an embolization procedure for whatever reason, perhaps even the rare anastomosis case. But as you're saying, if there's some kind of problem or issue during the procedure, there is the option to say, we don't have to proceed, a surgical option may be better for this person. So I do think that, perhaps people need to understand that what you are suggesting or what you're bringing to the table is a procedure that perhaps could come before surgery because of the reduced risk and reduced impact, I guess, on your quality of life. Is there any time, so let's say somebody comes and has an embolization procedure, great, fibroids are gone,
will she need to do the procedure again? And if so, what's the time
So
frame?
it really depends. It really depends on what age patients come present. So the ideal patient is usually over 35.
Okay.
You know, so if you are embolizing fibroids over 35, the fibroids, the growth of fibroids is very linked to your hormone status. So if you embolize them at age 35, there is a very low chance that they will recur.
Right.
But in very young patients with fibroids, it can be done, but there's a good chance that they could recur.
Okay,
Yeah.
just because of time.
But I mean, it's such a minimally invasive procedure. Why not re-embolize?
Right.
You know, suppose the options are, okay, well, I'll go and, like say you're like 25 years old and you have fibroids and maybe you're struggling to fall pregnant and then you go and you have this myomectomy where they remove the fibroids themselves. And then maybe when you're 35 now they happen again.
Right.
You know, having surgery multiple times only increases in your risk of complications.
Right.
So I don't see that as being a reason why patients shouldn't choose fibroid embolization. But the ideal candidate is usually, you know, we don't want the ladies to come back. We want them to have
have
a good life once done.
Right.
But I mean, if you come quite young and you may be having fertility problems, and because, you know, the reasons why people have fertility problems is because these fibroids are so big that they mangle up the uterus. It stops the normal flow of everything.
Right.
So by reducing the size of the fibroids, you have a normal shape and form, and you'll have your normal periods, etc. that can happen. So it's quite a contentious issue, the younger patients.
Yeah.
But I
Because
think
I'm pretty sure there's lots of young patients under 35 would love to have this procedure.
But I think that if this procedure is to be done, it has to be in consultation with the gynecologists.
Okay.
And we will make, myself or an interventional radiologist and a gynecologist will make an informed decision here about what are in the patient's best interests.
Right.
Yeah.
Who's paying for this? Can medical aid pay?
So surprisingly, fibroid embolization is one of the, Discovery, for example, approves them like this. And probably the reason why they do that is because patients, there's a proven track record and there's research behind it. And on top of that, they know that when you have these procedures, it saves the medical aids money because you're not in the hospital for longer, your procedures on one day, they save money. So it's in their best interests. And I think that's the whole thing about interventional radiology is that it is a cost-saving technique or type of medicine. You know, so that's why a lot of these medical aids are saying, look, why go and have these operations when patients can get out of hospital quickly so we can save some money.
Smart. So Dr. Creamer, how many interventional radiologists are there in the country that you know?
So with trained interventional radiologists, they're probably less than 10.
What?
Unfortunately, yeah.
Jeez.
Yeah, so...
we need more.
We do, and that's why I've started a training program at Hospital.
That's amazing news.
Yeah,
Yay. I'm so happy to hear that because I was just thinking not everyone's going to go to Canada.
No.
Hey?
Yeah.
Wow, that is amazing.
Yeah.
I think it's fascinating the work that you do, and I know that there are a few other gynecological procedures that you are able to assist with. We will definitely, hopefully, soon talk about those. But it's been an absolute pleasure to chat with you, and we have been talking back and forth, but just having this conversation with you, my mind is blown. Incidentally, I had a fibroid found at one of my surgeries before. It didn't obviously require anything because it was just kind of hanging out there. But when you say how common fibroids actually are, this is a massive women's health issue. And I do think that this conversation is hopefully going to assist, and I hope that you found it helpful. So how do people get hold of you? Where can people get more information about Dr. Dale Creamer, but more specifically, where can they get information about their options and more information perhaps about fibroid embolization.
Yeah, so I'm pretty much on all types of social media now. That's Instagram, Facebook, YouTube, TikTok. Goodness,
I hope
I don't know. Luckily, I have a PR company handling these things.
Okay.
I don't have the time to handle it, to manage it. But the most important source of information will come from the website, which is www.ctir.co.za.
Okay.
If you click on Women's Health, there's a few procedures that ladies should go and have a look at,
Oh, wow.
and where we can help them in a very minimally invasive way.
Oh, this is so exciting. You have no idea how this makes my heart happy because, yeah, as I said, loads of people reaching out to me, very little that I've been able to help with regarding, some options with or what is available for fibroid management. But there you go. And yeah, thank you so much, Dale, for coming through and chatting with me. It's been an absolute pleasure. If you have any questions about fibroids or anything else that you find on Dr. Dale's website, please come back to this post, leave a question in the comments, and we will be happy to get back to you. It's been an absolute pleasure. I hope that you've found this helpful, and I hope that you've learned something. For those of you who don't know, I'm Dr. Carmen, and this is Dr. Dale Creamer, and it's been an absolute pleasure. Take care.
Cheers.
Bye.
Bye-bye.